This recorded lecture will be going over Chapter 19, Care of Patients with Cardiac Disorders. More than 6.2 million Americans have heart failure, and heart failure is a primary or contributing cause to approximately 380 deaths each year. Half of patients diagnosed with heart failure will die within 5 years. African Americans have a higher incidence of heart failure and have a higher mortality rates than other populations. Heart failure may be acute or chronic, mild or severe. The New York Heart Association scale identifies 4 stages of heart failure, classified according to exercise tolerance. They have identified stages of heart failure from A to D, and you can see these on page 435. The most common causes of heart failure are coronary artery disease and uncontrolled hypertension. The key words to understanding heart failure are congestion and increased pressure. Congestion develops because the heart is unable to move the amount of blood it receives efficiently through the system. Therefore, the vessels cannot accommodate a normal supply of blood, causing the heart muscle to become exhausted, trying to overcome the resistance in the vessels. Heart failure may be classified as right-sided heart failure or left-sided heart failure. The heart has 2 pumps, a right-sided and left-sided pump. The right-sided pump receives blood from the body and pumps it to the lungs for oxygenation. The left-sided pump receives blood from the lungs and pumps it out to the body. Clinically, it is rare to see pure right or left-sided failure. The circulatory system is a continuous circle, and eventually all congestion or increased pressure will affect both sides of the heart. Left-sided failure will typically occur first. This will cause fluid to back up into the pulmonary vessels. The pressure within those vessels will increase, and fluid leaks into the lung tissue, producing congestion and eventually pulmonary edema. Primary right-sided heart failure is commonly caused by chronic pulmonary disease. Chronic lung disease causes scarring, making it harder for the ventricle to eject blood into pulmonary circulation. This increased resistance will require the right ventricle to squeeze harder, generating more pressure and causing inadequate injection. As pressure in the peripheral vessels increases, the fluid from the intravascular fluid compartment will begin to leak into the interstitial compartment. This produces edema. When the right side of the heart fails, the edema is first evident in the lower extremities. The systemic backup of blood that occurs in the right-sided heart failure will eventually lead to left-sided heart failure, because the heart will have to pump against increasing pressure in the aorta and the systemic circulation. Left-sided heart failure is subdivided into systolic and diastolic heart failure. Disorders leading to heart failure that cause problems with filling are called diastolic failure, and those that affect the ejection of blood are called systolic failure. Systolic failure is caused by anything that interferes with the ejection of blood from the ventricles. The inability of the heart to pump an adequate amount of blood to meet the needs of the body can lead to problems in other organs. The ejection fraction is the percentage of the filling volume pumped out with each ventricular contraction. In a normal heart, the EF would be 55 to 70%. This means that 30 to 45% of the blood is left in the ventricle, allowing the body to increase its cardiac output when needed by increasing the force of contraction and ejecting more blood. An ejection fraction of 40% or less is a marker of systolic heart failure. Diastolic failure occurs when conditions prevent the filling of the heart with blood. Tricuspid and mitral stenosis, cardiac tamponade, or constrictive cardiomyopathy can cause diastolic failure. Decreased filling results in decreased stroke volume and cardiac output. Ejection fraction is normal in primary diastolic failure. A hallmark of diastolic failure is neck vein or jugular distension. Ejection fraction can be determined with echocardiography or left heart catheterization, and it is a key feature in determining the correct treatment. Initially, compensatory mechanisms will prevent the symptoms of heart failure. In left-sided failure, compensatory mechanisms will eventually weaken the heart, and the blood backs up into the pulmonary vessels. Pressure within those vessels increases, and fluid leaks out into the lung tissue, producing congestion. Fatigue and shortness of breath are first noticed with activity and when lying down. If failure progresses, pulmonary edema occurs. Diagnosis will be made primarily on clinical signs and symptoms and careful history. Helpful diagnostic tests include chest X-ray, echocardiogram, ECG, MRI, electrolytes, CBC, and BNP. BNP measures the level of a protein released when myocardial cells are stretched. A level greater than 500 pg per ml is consistent with heart failure when other symptoms are present. Advanced systolic heart failure signs are S3 and S4 heart sounds. A weight gain of 2 to 3 pounds in 24 hours, or 5 pounds in 1 week, will occur as fluid is retained. Dyspnea will be present, and crackles or wheezes can be heard in the lungs. Dysrhythmias will be controlled. Surgical correction of valve or septal abnormalities can reverse heart failure. Medical treatment is largely symptomatic and depends on the type and degree of heart failure present. Drugs and other therapies can be used to reduce or eliminate the symptoms and complications of heart failure, but they will only control the condition, not cure it. For patients experiencing heart failure, efforts will be made to reduce the demand for oxygen and the workload of the heart, strengthen the heart's pumping action, relieve venous congestion in the lungs, and minimize sodium and water retention in the tissues. To accomplish the goals of medical intervention, the following medications may be prescribed. ACE inhibitors and ARBs, decreasing the workload of the heart by causing vasodilation. Beta-adrenergic blockers can be used to slow the rate if tachycardia is causing heart failure, therefore decreasing the oxygen demand. Diuretics, especially loop diuretics, will be prescribed to reduce fluid retention in the lungs and lower extremities. Digitalis is occasionally used to increase the force of heart contraction and slow the rate, therefore increasing the cardiac output. It is also the most commonly used drug in this category is digoxin. This drug is not recommended for older adults. This drug is not recommended for older adult white women because it increases mortality rates in this group. Venous vasodilators like Isordil and nitroglycerin can relax and dilate blood vessels, allowing the vessels to accommodate larger percentages of total blood volume. Morphine can be prescribed if pulmonary edema is present to relieve anxiety and make breathing easier. Benzodiazepines can be used for anxiety and reduction of emotional stress. Limited physical therapy or bed rest in a semi-Fowler or high Fowler position can decrease the workload of the heart and help breathing. Oxygen therapy can help optimize the amount of oxygen available to be delivered into the tissues. Intravenous inotropes can be used for acute systolic heart failure to improve cardiac contractility. Additional treatments could include cardiac resynchronization therapy. These are when pacing wires are attached to a pulse generator placed into the heart to send electrical impulses to the right and left ventricles so they contract at the same time. A left ventricular assist device, or LVAD, can be used to help with the heart's pumping action. This device can be used while the patient is awaiting transplantation and, with continued research, could potentially eliminate the need for transplants in some patients. The temporary placement of a small catheter-based pump can also help improve left ventricular function. Surgery to reduce the size of an enlarged heart may be effective for some patients. And sometimes a heart transplant could be the only alternative for patients with advanced heart failure who do not respond to other medical or drug treatment. Short-term treatment for severe heart failure can be accomplished with an intra-aortic balloon pump. The IABP is positioned in the descending aorta and is designed to increase blood supply to the myocardium and decrease the workload. Acute pulmonary edema is a medical emergency that must be treated promptly. A patient with this condition has severe dyspnea, a cough productive of frothy, pink-tinged sputum, tachycardia, and moist, bubbling respirations with cyanosis. Nursing interventions for acute pulmonary edema include placing the patient in a high Fowler's position to relieve the dyspnea, administering oxygen, diuretics, morphine, and other prescribed drugs, limiting and monitoring activity, and assessing cardiopulmonary status. The effects of heart failure can range from very mild to very serious. It is important to ask the patient if clothes, rings, or shoes fit tighter than previously, indicating edema. Always obtain an accurate weight and assess the trend of weight. Inquire how much activity causes shortness of breath. Assess the diet to determine usual sodium, fat, and calorie intake, and always obtain a smoking history. Significant findings in left-sided heart failure include increasing fatigue, dyspnea and a dry hacking cough, crackles heard upon auscultation, pale, cool, clammy skin, diminished peripheral pulses, dizziness, confusion, restlessness, and difficulty concentrating and remembering, gradually increasing heart rate, the extra heart sound of S3 or S4, and a decreased blood pressure as the ventricles fail. Significant findings in right-sided heart failure include a weight gain without a change in caloric intake, dependent pitting edema, jugular venous distension, reduced urinary output, an increase in blood pressure from the fluid overload, and waking up at night after a few hours of sleep due to PND. Heart failure is a chronic disease. Patients will require instruction in self-care. Instruction should include balancing rest with physical activity, limiting sodium intake, and following other dietary restrictions. The entire family should be included in the dietary teaching. Immunizations against the seasonal flu and pneumonia should be encouraged. It is of vital importance to monitor patients with heart failure for electrolyte imbalances, especially imbalance of sodium or potassium. Electrolyte imbalances could cause serious cardiac dysrhythmias. Patients with chronic heart failure will need encouragement to follow the prescribed regimen. If treatment does not stop the progress of the disease, the patient may be admitted to the hospital for reevaluation and a change in therapies. Sometimes the patient's heart continues to fail despite aggressive therapy, and pulmonary edema and liver and renal failure will occur. Assisting hospitalized patients with activities of daily living can decrease oxygen demand. Scheduling all activities to promote as much rest as possible is a high priority. Activity should be alternated with rest throughout the day. Monitoring intake and output is very important. Daily weight is recorded at the same time each day, preferably before breakfast. Bed rest will cause venous pooling, and DVT prophylaxis should be implemented. Heparin or enoxaparin can be used unless the patient is already taking an antiplatelet or an anticoagulant medication for another reason. Careful ongoing physical assessment is essential. Instructional materials regarding smoking cessation are offered to all smokers on admission and discharge, and patients should be counseled about the importance of quitting smoking. Discharge instructions will include activity level, diet, discharge medications, follow-up appointment, weight monitoring, what to do if symptoms worsen, and when to notify their healthcare provider. Observe the patient for an improvement of symptoms, including edema, respiratory quality, and activity intolerance. Improvement will be an indication of patient progress. An abnormal heart rhythm will occur when the conduction system of the heart muscle is not functioning normally. Alterations in the conduction of cardiac electrical impulses that create heart rate and rhythm may be the result of congenital abnormalities, electrolyte disturbances, too much caffeine, illegal drug use, stress, or medication side effects. Abnormal rhythms are known as arrhythmias or dysrhythmias. The SA node will generate electrical impulses 60 to 100 times per minute. If the SA node fails to produce an electrical impulse, the AV node will initiate an impulse at 40 to 60 beats per minute. If neither the SA node nor the AV node is functioning, the Purkinje fibers in the ventricles will initiate an impulse at a slower rate. Bradycardia may or may not be a problem. Athletes often have a bradycardia without pathologic condition because their hearts are so well conditioned that they are very efficient. Whether a bradycardia requires treatment will depend on whether or not the patient has symptoms of decreased blood flow. Symptomatic bradycardia is treated with atropine or pacing. In an emergency, external pacing pads can be used until a different mode of pacing can be implemented. Sinus tachycardia with a rate of 100 to 150 beats per minute is typically caused by pain, fever, stress, hypovolemia, or hypoxia. Increasing heart rate is the body's response to the need for increased blood flow. Cardiac output will fall. Heart rates over 150 beats per minute are considered too fast for most patients. Symptoms that the patient could experience include dizziness, palpitations, fatigue, chest pain, hypotension, and loss of consciousness. Even death could occur. It is important to be able to recognize a normal heart rhythm so that abnormalities can be quickly identified. The heart rate is the single best indicator as to how the patient may be tolerating a heart rhythm. The name of the rhythm will indicate where the electrical impulse originated to cause the QRS. The only time a bradycardia is treated is if the patient has symptoms of decreased cardiac output. Slow heart rates can be caused by hypoxia, electrolyte imbalances, infection, drugs, hypoglycemia, and other treatable conditions. Sinus bradycardia is the most common form of bradycardia. The rhythm will look like a normal sinus rhythm except for the rate. Bradycardias can also be produced by conduction problems like heart blocks. In heart block, the signal is stopped either temporarily or permanently at the AV junction. Heart block is either first, second, or third degree. The higher the degree, the more significant the block, and the more likely it is to produce bradycardia. First degree block could be temporary or permanent. It usually will not cause hemodynamically significant symptoms. Second degree heart block has two types. The first is a Mobitz 1 or Wenckebach, which displays a normal R-to-R interval on the EKG and then an increasingly lengthened PR interval until the P wave appears without a QRS complex because the impulse was not conducted to the ventricles. The arrhythmia is most often transient and rarely progresses to third degree heart block. It is considered benign. Type 2 second degree heart block, or a Mobitz 2, is more severe. There may be a single or multiple P waves throughout a QRS. The PR interval will be constant throughout. This rhythm is dangerous because it may progress to third degree heart block and it is most often caused by ischemia. In complete heart block or third degree, the AV node does not conduct atrial impulses to the ventricles. This dysrhythmia can be life-threatening, but many times an adequate heart rate is present to allow time for intervention. All bradycardia will be treated the same, so initially, specific identification will not be necessary to implement the correct therapy. Supraventricular tachycardia, or SVT, is a rhythm that originates in or above the bundle of His. SVTs can include atrial flutter or fibrillation, atrial tachycardia, and junctional tachycardia. The heart rate will be greater than 150 beats per minute, and the QRS will be of normal duration. If the patient is unstable, a synchronized cardioversion will be implemented. For stable patients, vagal maneuvers and drug therapies will be used. Ventricular tachycardia is a potentially life-threatening dysrhythmia that is generated from one or more focal points in the ventricle at a very fast rate. The patient may be awake and alert without symptoms or just not feeling well, or the patient could be pulseless. The EKG tracing will not tell you if the patient has a pulse, so you have to feel for it. Ventricular tachycardia occurs in bursts, short runs, or as a sustained rhythm. Cardiac output will fall drastically. VT can quickly deteriorate into ventricular fibrillation or a cardiac standstill. If the patient is symptomatic with changes in blood pressure, pulse, and level of consciousness, the VT is considered unstable. A synchronized cardioversion should be started at 100 joules. If the patient is not unstable, treatment with oxygen and amiodarone will be provided. VT is typically caused by cardiac ischemia or any condition or substance that causes myocardial irritability. New onset atrial fibrillation usually presents with a very rapid heart rate. Patients will be admitted with AFib with RVR. This is atrial fibrillation with a rapid ventricular response. Some patients will be lightheaded, have a decreased blood pressure, and may be clammy. AFib can occur with heart failure, coronary artery disease, hyperthyroidism, or COPD. Instead of atrial contraction, there is quivering P waves. There is quivering, and P waves are not listed on the EKG tracing. It is considered an irregular heart rhythm. This rhythm is typically irregularly irregular. Treatment is with loading doses of diltiazem or digoxin, amiodarone, or a beta blocker. If drug treatment is unsuccessful, synchronized cardioversion will be performed to convert to a normal sinus rhythm. AFib will predispose the patient to clot formations in the atria. Patients with chronic AFib are typically placed on an oral anticoagulant therapy. Several devices to block off the opening to the left atrial appendage are available and in use for patients in which anticoagulation is contraindicated or impractical. Ventricular fibrillation, or VF, is a chaotic rhythm, random firing of all the ventricular cells. The ventricles quiver rather than contract. There is no cardiac output, and without CPR and defibrillation, death will occur. There is no pulse and no blood pressure. The ECG will show a coarse electrical waveform varying in size and shape, and no intervals can be determined. Intermediate intervention is required. A pulse must be determined by assessing the patient. Severe acidosis, electrolyte imbalances, profound hypovolemia, and other disorders will keep the myocardium from contracting due to a toxic environment. In pulseless electrical activity, a signal is sent and a QRS appears on the EKG, but there is no pulse. The most common rhythm displayed is sinus tachycardia. CPR and correction of the underlying disorder is the only way to regain a pulse. The prefix A means without, so asystole is without systole. Asystole is also called a flat line, since there is no electrical activity in the heart. Asystole is rarely a presenting rhythm, but is seen at the end of a failed resuscitation effort. An extra heartbeat that interrupts the regularity of the rhythm can be caused by an impulse coming from the atria, junction, or ventricles. Because they occur outside their normal location, they are considered ectopic. The premature ventricular contraction, or PVC, will appear on the EKG as an early beat without a P wave and a wide QRS complex. A ventricular impulse will cause a ventricular contraction. It is labeled premature because it comes early. The patient perceives a PVC as a skipped beat because the PVC is not efficient at pumping blood and may not generate enough blood flow to be felt at a pulse point. PVCs may be from caffeine, drugs, or increased emotional stress. The most common rhythm displayed is sinus tachycardia. CPR and correction of the underlying disorder is the only way to regain a pulse. For PEA. The patient will perceive a PVC as a skipped beat because the PVC is not efficient at pumping blood and it may not generate enough blood flow to be felt at a pulse point. PVCs may be from caffeine, drugs, or increased emotional stress. A few PVCs are not abnormal, but when there are more than 6 or 7 in a minute, cardiac output could fall. 3 or more PVCs in a row are considered ventricular tachycardia. PVCs may not all look alike. Premature atrial contraction, or PAC, happens when an ectopic electrical focus fires before the next SA node impulses do, thereby depolarizing the atria. An abnormally shaped P wave will appear on the ECG before the QRS wave. PACs are common and do not often produce symptoms. PACs result from sympathetic nervous stimulation, like that occurs with anxiety, hypoxia, or ischemia. Early junctional beats can also occur and are called premature junctional contractions. They look a lot like PACs, but usually do not have a P wave in front of the early beat. Most of the premature beats are caused by irritability of the tissue. The more frequently the premature beats occur, the more concern that you should show. All nurses should be able to recognize a life-threatening dysrhythmia. Disorders of the cardiac conduction system are diagnosed with a 12-lead EKG by continuous EKG monitoring and patient history. Oxygenation, acid-base status, and electrolyte balance are watched carefully and corrected as needed. Early recognition and correction of abnormalities will decrease the occurrence of life-threatening dysrhythmias. Patients who experience tachycardia or rhythms that do not respond to drug therapy may be treated with a synchronized cardioversion. A mild electrical shock is delivered to the heart at a specific time in the cardiac cycle to interrupt the abnormal rhythm and begin a new, normal rhythm of electrical impulse and contraction. The procedure is done emergently when the patient is unstable and requires immediate intervention. This can also be done electively as a scheduled procedure, primarily to convert AFib to a normal rhythm. Signed consent is required. Resuscitation equipment must be at hand. Cardiac pacemakers may be used to manage chronic and life-threatening dysrhythmias. These are used to support the heart rate when bradycardia occurs. A pacemaker can be used to pace the atria and one or both ventricles. Some units can override a dysrhythmia and keep the heart at a more steady rhythm. Pacing can be a temporary measure if the problem is an emergent, transient condition, like drug toxicity. An external pacemaker is often used in the emergency department. Electricity is passed through the chest wall via external pads. This causes uncomfortable muscle contractions as the current passes through the chest, so it is used only until another mode of pacing is available. A temporary transvenous pacemaker is placed if a transient rhythm like a heart block develops after an MI or drug toxicity. Patient consent is required and a sedative should be given to the patient before the procedure. A permanent pacemaker is implanted for SA node dysfunction, heart block, or treatment of chronic heart failure. All pacemakers have the same function, to produce effective heartbeats. Assess the patient's learning needs. Seek to identify the source of any fear and gauge their level of anxiety. Both the AHA and the manufacturers of pacemakers will provide illustrated booklets to help patients learn more about their cardiac pacer. Postoperative nursing care for patients with a permanent pacemaker will include continuous monitoring of the heart rate, rhythm, blood pressure, and temperature. The battery in a pacemaker should last 6 to 9 years, depending on how frequently the pacing is required. The patient should understand the importance of periodic evaluations of their condition for the rest of their life. Instructions for the use of the pacemaker and monitoring device are included in the owner's manual. Implantable cardioverter defibrillators, or ICDs, are used for patients who have an episode of a life-threatening dysrhythmia. The defibrillator will be implanted in the same way as a pacemaker. The pulse generator is slightly larger than that for a regular pacemaker because it requires a high-capacity battery. ICDs will monitor the heartbeat and provide an electrical shock similar to that delivered in a cardiac defibrillation or cardioversion when a life-threatening rhythm is detected. Most ICDs can pace as well as defibrillate. A magnetic field will temporarily inactivate the device. Moving away from the magnetic source can restore normal function. When drugs will not control supraventricular or ventricular tachydysrhythmia, the irritable focus can sometimes be destroyed with a radiofrequency catheter ablation. A specially trained healthcare provider can use this radiofrequency wave to destroy the irritable focus via heart and subsequent scarring. Infective endocarditis is an infection of the endocardial surface of the heart. Infective endocarditis may be caused by bacteria, viruses, or fungi. Ports of entry are the oral cavity, particularly with dental procedures, the skin from surgery or invasive procedures, and infections in the body. IV drug use with unclean needles is a major cause of endocarditis. Rheumatic fever causes injury to the heart valves. Throat culture should be performed anytime that there is a question whether group A beta hemolytic streptococcus is the organism responsible for a sore throat. The inflamed tissues of the heart become rough and swollen. The inflamed tissue will trap organisms. The bacterial growth on the valves are called vegetations. Vegetations can decrease the effectiveness of the valve. Emboli from the right side of the heart become pulmonary emboli, and those from the left side of the heart will usually go to the brain, but they can travel to other organs. The signs and symptoms of IE will vary considerably. The sedimentation rate, or CRP, and leukocyte count are elevated, and signs of low-grade intermittent fever are evident. A blood culture will be positive. Echocardiography, or TEE, can confirm the diagnosis. Fatigue, chills, and sweats, malaise, anorexia, muscle aches, and headaches can occur. An existing cardiac murmur can worsen, or a new murmur could appear as a valve is damaged. The scar tissue that occurs as the inflammation subsides may cause the valve to leak, resulting in regurgitation, or the valve leaflets may become thickened and calcified, causing narrowing or stenosis. The mitral and aortic valves are most commonly affected. Stenosis and regurgitation of cardiac valves could eventually cause heart failure. Treatment for IE is with antibiotics for 4 to 6 weeks for the underlying infection. NSAIDs are used to decrease inflammation. Pericarditis is an inflammation of the pericardium. Pericarditis may be caused by cancer and its treatment, systemic connective tissue disease, infectious organisms, renal failure, trauma or tissue damage from an MI. If the effusion becomes large, it presses on the ventricle, restricting filling, which can affect the cardiac output. Should the fluid become excessive, cardiac tamponade may occur, as the fluid severely limits filling, resulting in a little blood available to be pumped out of the heart. Symptoms of pericarditis include fever, tachycardia, chest pain eased by sitting up and leaning forward, dyspnea, and a pericardial friction rub. Dressler syndrome is pericarditis with effusion occurring from inflammation after an MI. It appears 1 to 12 weeks after infarct. Assess for fever, muffled heart sounds, tachycardia, restlessness, anxiety, and confusion, distended neck veins, and pulsus paradoxus. This is a drop in the systolic blood pressure greater than 10 millimeters of mercury on inspiration. Diagnosis of pericarditis can be made by history and physical examination and confirmed by EKG, echocardiogram, CT scan or MRI, and lab studies of CRP, CBC, and ESR. A pericardiocentesis could be performed if the effusion is interfering with cardiac output. Assess heart sounds carefully. Assess vital signs on a regular basis and note any abnormalities. The teaching plan should include information about the drugs as well as detailed information about the specific disease process. Activity restrictions are determined by patient tolerance. Home IV antibiotics may be required for weeks after discharge. Advise that prophylactic antibiotic therapy is necessary before dental procedures that involve gingival manipulation or bleeding. Cardiomyopathy is a group of diseases that affect the structure or function of the heart. The risk of cardiomyopathy is increased in systemic hypertension with chronic excessive alcohol intake during pregnancy, and in those who have had a systemic infection. The heart enlarges and becomes an inefficient pump. There are 3 main types of cardiomyopathy: dilated, hypertrophic, and restrictive. The major problems exhibited by patients with cardiomyopathy are heart failure and dysrhythmias. Signs and symptoms of cardiomyopathy include dyspnea, activity intolerance, angina, dizziness, hypertension, and palpitations. Diagnosis is made through history and chest X-ray, cardiac catheterization, echocardiography, ECG, or MRI or CT scans. Medical treatment for cardiomyopathy includes drugs to increase contractility, antihypertensive drugs, diuretics, antiarrhythmic drugs, and anticoagulants. Severe cardiomyopathy can be rapidly fatal. Heart transplantation is indicated when conventional treatments are no longer effective and the patient has a projected lifespan of 1 year or less. Transplants due to cardiomyopathy account for 99% of heart transplants. If heart failure symptoms occur, they are most likely indicating rejection of the transplanted heart. Most rejection is identified by biopsy during routine checks prior to symptoms occurring. Mitral and aortic valve disorders are the most common cardiac valve disorders. Mitral valve prolapse occurs when the valve leaflets and tendon-like cords supporting the valve weaken and prolapse into the left atrium during systole. This is most often a benign condition. Mitral stenosis is the most commonly caused by rheumatic fever. Other causes are systemic lupus erythematosus, rheumatoid arthritis, and related conditions. Pulmonary pressure increases, pulmonary congestion occurs, and over time the right ventricle hypertrophies. The first symptom may be dyspnea on exertion. If untreated, right-sided heart failure may eventually occur. Treatment is based on the stage of mitral stenosis identified by intracardiac pressures and clinical symptoms. Rheumatic heart disease is the main cause of mitral regurgitation. The left ventricle and left atrium will dilate and hypertrophy to accomplish the ejection. More women than men develop mitral regurgitation. Symptoms will take decades to emerge. Fatigue and weakness from reduced cardiac output are early signs. Dyspnea on exertion and orthopnea are later developments. Aortic stenosis is the most common valve disorder in the United States. Atherosclerosis with degenerative calcification of the valve is a common factor in older adults. Congenital valve malformations and rheumatic fever are causes in younger patients. Eventually, cardiac output is decreased to the point that the body's demands cannot be met during exertion. Systolic heart failure begins, and pulmonary congestion produces symptoms. Dyspnea, angina, and syncope on exertion are classic symptoms of aortic stenosis. Later, extreme fatigue, weakness, and peripheral cyanosis become apparent. A narrowed pulse pressure is found when blood pressure is measured. Auscultation reveals a systolic crescendo-descendo murmur. Ineffective endocarditis, congenital abnormalities, long-term hypertension, and Marfan syndrome are factors in aortic regurgitation. Symptoms do not appear until left ventricular failure happens. Dyspnea on exertion, orthopnea, and paroxysmal nocturnal sleep dyspnea begin. Treatment depends on the valve affected and the degree of impairment. Yearly monitoring and drug therapy for symptoms is standard when disease is not severe. Diuretics, beta blockers, digoxin, and oxygen, along with the rest, are used to improve symptoms of heart failure and dysrhythmias. Patients with chronic AFib are prescribed regular anticoagulant therapy. Medical treatment is not the treatment of choice. Interventional procedures are the only effective treatment for the problem. When valvular disease becomes severe, surgery is required to correct the problem. Balloon valvuloplasty is sometimes used to open stenosed valves. Mitral valve annuloplasty is performed for acquired mitral valve regurgitation. Valve replacement may be performed as an open heart procedure with cardiopulmonary bypass or as a minimally invasive surgery. Many mechanical and biological valves are available. Mechanical valves will require lifetime anticoagulation postoperatively due to the possibility of clot formation. Biological valves may be from a pig, from a cow, or from a human cadaver. Biological valves will tend to wear out in about 15 years, requiring replacement. Mechanical valves are more durable. Transcatheter aortic valve replacement is an emerging technology that allows for replacement of the aortic valve via a percutaneous approach rather than a thoracotomy. The primary nursing goals for patients with cardiac valve disease are to maintain adequate cardiac output, to control dysrhythmias, and to prevent or control heart failure. Valve surgery is most often an elective procedure. Patients taking anticoagulation drugs preoperatively must stop taking them about 72 hours before the procedure. Patients with mitral stenosis may have pulmonary hypertension and stiff lungs. Postoperatively, respiratory status must be monitored very closely during weaning from the ventilator. Fatigue is a common problem during convalescence. Rest and activity should be balanced carefully. The medical treatments most commonly used to manage heart disease include oxygen therapy, pharmacological agents, surgical and interventional procedures, and dietary controls. Administering supplemental oxygen to relieve the dyspnea and hypoxemia of a cardiac patient is a routine therapeutic measure. Any patient experiencing chest pain is started on a low-dose oxygen. It is important to be alert for signs of changing oxygen needs, like increased pulse rate and symptoms of cerebral anoxia, including irritability, confusion, and disorientation. Classic symptoms of digitalis toxicity are yellow-green halos around lights, nausea, diarrhea, and confusion. Digitalis can be very effective in treating certain kinds of cardiac disorders, but its therapeutic range is quite narrow. Antilipids are used to control the atherosclerotic process. Anticoagulants will not dissolve clots that have already formed, but they can prevent existing ones from growing larger and can interfere with the development of new clots. The National Heart, Lung, and Blood Institute cites obesity as a risk factor for cardiac disorders. Many healthcare professionals consider self-help groups to be the most successful way to assist people to lose weight and then keep their weight within a normal range once the excess is lost. Groups include Weight Watchers, TOPS, and Overeaters Anonymous. Increased fiber can lower cholesterol without cutting down on dietary fat. Adults should consume about 35 grams of fiber per day. The national average consumption is about 12 grams. Increasing fiber in the diet also lowers the risk of cancer and helps with weight control by maintaining a feeling of fullness for longer. Foods containing trans fat increase the cholesterol level, especially low-density lipoprotein. Patients should be taught to read food labels for the presence of trans fat. A high intake of sodium is believed to contribute to the development of high blood pressure. Limiting sodium intake is an important part of preventing and treating hypertension. Patients with infectious and inflammatory disease of the heart should be sent home after a few days in the hospital. A thorough heart and lung assessment will be performed at every home visit. You can teach your patient or family how to infuse the antibiotics and how to care for their IV or PICC line. The importance of tracking temperature daily should be stressed. Signs and symptoms to report to the healthcare provider should be reviewed, including any new or increased chest pain, dysrhythmia, fatigue, shortness of breath, change in level of consciousness, sharp abdominal pain, or dependent edema. Nurses in long-term care settings must be vigilant for the beginning signs of heart failure because many older adult residents have had chronic hypertension, previous MIs, or previous episodes of heart failure. Heart rates and rhythms should be monitored closely, and fluid and electrolyte replacement should begin early in the course of the illness.